Right, good afternoon everyone. I think we'll make a start now because I've just had a couple of questions come up from you about whether we're actually broadcasting and why you've been muted. Okay, and it looks like most of you have joined on there. So there is an opportunity to type in questions, so if you do have any questions as we go through, if you type them in at the end, then I'll do my best to answer them. Obviously it's a little bit tricky on this because I'm just in a quiet room looking at a blank screen, whereas if I was in an audience hall you could put your arms up and ask questions as we go through. So it's a bit of a new thing for me. So today is a little bit of a follow-on from a blog which I wrote the other week. And I want to talk about the assessments which we routinely do in the clinics or in our clinics and have a look at why we do them and what the evidence is. I think sometimes perhaps we're all a little bit guilty, and I know I certainly am, of just using assessments which work for us and not actually reviewing the evidence behind them. Having said that though, if we do what works for us and we get good outcomes, then maybe that's a justification in itself. But what I don't want to do with this presentation is tell you what you should and shouldn't be doing. The idea of the webinar is to give you some food for thought, and hopefully there'll be something in there which you can take away with you at the end and use it in your clinic. Now, first and foremost, and this is a fact, biomechanical or MSK assessment forms vary greatly from health service to health service and practice to practice and probably country to country as well. So some will have a very comprehensive form like the one I talked about in my blog last week, where every conceivable measurement you can possibly think of is listed and you have to fill it in, well, if you want to. Some places will just have almost a blank page with nothing on it. I've also seen many assessment forms which don't even have a diagnosis box. Now, this bit is pretty crucial if you are diagnosing the patient, so do make sure you have one of those if you're thinking about reviewing your assessment forms. Now, I've popped a quote on there. In 2002, a research paper concluded that there was no clear method for classifying foot type and little research to predict dynamic foot function. Now that is quite an old quote now, it's going back over 10 years, but a paper which came out earlier this year said pretty much the same thing, and I will mention and talk about that paper, that particular paper, a little bit later in the presentation. So what do we look at the moment? I've listed a few tests on here. I'm not going to look at every single test that most people do use, don't use, or maybe they may use. But these ones tend to come up time and time again, and they do tend to be debated a lot. Now, I know a lot of clinicians who still measure NTSPs and RCSPs, and I also know a lot who are dead against it, and they have very good reasons for being dead against it. But I think the main point here is not to say you definitely shouldn't use it, but if you do use it, to understand that it's not necessarily very accurate and you know, think about what you're using it for. Ankle joint range of motion is a common test used not only in podiatry but across the board of clinicians who treat and assess the lower limb in general. But again, a lot of people use it, but what does it actually tell us? And then there's the mid-tarsal joint axis. Now, I remember as a newly qualified clinician trying to get my head around this one and what the implications were for a high or a low axis, or an oblique or an medial or whatever it was I read about at the time. I remember at the time it made perfect engineering sense, but as we all know, the body doesn't always follow mathematical rules and fit into those nice little categories. So let's look a little bit more closely at RCSPs and NCSPs, as I know that that's quite a hot topic sometimes. Now, I've mentioned a couple of studies on here, but there are plenty of papers out there which have found that these measurements are neither repeatable or reliable. And aside from anything else, the skin and the fat pad moves from non-weight bearing when you bisect the calcaneus, get your pen out and draw the line on, to when you then stand the patient up. So that line you've drawn on could move a couple of degrees. Now, a lot of clinicians like this test because it gives you a measurement or a starting point, and for those that are a little bit more mathematically inclined, it gives you more of a quantitative feel. So, you know, it gives you a number or a measurement. Now, I often feel that Root gets quite bad press with this one. But if you take the time to read his papers, you'll see that he doesn't actually mention this perfect joint position, and he doesn't say anything about actually palpating the talar head. He just talks about the subtalar arch. To a certain extent, although we've moved on a lot from some of these original root theories, some of the newer ideas which are out there still use some of the old root principles to base the newer ideas on. And a bit later on we'll come on to the foot posture index, as I say, which I'll come on to. And there's an observation on there which actually looks at the RCSP, so I think it is still quite important to understand this assessment. And another point I'll make about this, and this is just my opinion, and I did mention it in my blog, but when you're informing the patient about what you're trying to do and explaining what's happening with the foot, whether it's pronating or supinating or what their condition is, drawing a line on the back does help them understand, especially if you've got parents coming in with children. And I think that's really because you make it more visual. Right, okay, let's move on to the next slide. Now, certainly when I first qualified, it was all about the subtalar joint, and everything seemed to revolve around this. The magical perfect position, the subtalar joint neutral, and then the dreaded. So we had the dreaded overpronation versus the perfect neutral position, and that's what we all sought out to find. Menz, quite a few years ago, in 1998, said that the most significant motion occurring within the rear foot complex during pronation and supination movements actually takes place at the talonavicular joint. So if we look at our little picture here, we've been concentrating on this area, and it's not to say you shouldn't, it's still a very important joint, but we should also be looking at the talonavicular joint and what's that doing, what that's doing. So that's important to bear in mind. So what about assessing the ankle joint range of motion? So typically we lay our patients on their front, we need 10 degrees of dorsiflexion, but where does that 10 degrees actually come from? And how hard do you have to push? Well, somebody said to me once that what you need to do is get a pair of scales or a set of scales, and you need to push down so you get 10 kilos, and that's how much pressure you need to apply. So, sounds easy enough. But what does this actually mean when the patient's standing or walking or running? Where does that 10 degrees come from? Now, there is a research paper out there by Dannenberg which tells us that we need 10 degrees, but if you actually read that paper through, it doesn't say where he got that figure from. And from a functional perspective, actually the lunge test will tell us a lot more about dynamic function of the ankle, and I'll come on to that a little bit later. Okay, so onto the mid-tarsal joint, movement of the mid-tarsal joint. Now this, there's a lovely, neat little explanation about the axes in the big grey Val Massey book, which I think a lot of you are probably very familiar with. But if you think about it logically and then think about the anatomy of the mid-tarsal joint in the foot, how can you have a joint that's got so many bones, articulations, muscle and ligament attachments? How can you only have two axes? Well, the simple answer to that is that you don't, and this was supported by a paper by Nestor and Finlow in 2006, who just said you simply can't mark all the different axes and articulations that you would get within that joint. So if you tried to do that, realistically, you'd probably end up getting that game kerplunk, where you've got all the different markers pointing out of it. So it's impossible to have that down to just two axes. Now, onto some tests which do have some research behind them. So some of you may use all of these, some of you may use some of you may use none. But the important thing is that they do all have research, and some of them do also have papers which link them to injury prediction. So what I'm going to go into in a bit more depth now is the foot posture index, subtalar joint axis location, supination resistance, navicular drift and drop, Jack's or Hubschers test, and the lunge test. So this is the foot posture index, just put a copy of it up there. And when I first saw this assessment, my first thoughts were that this is going to take far too long. If you work in a busy health service clinic and you've only got 10 minutes or 15 minutes, this is going to take too long. But in actual fact, once you try it a few times and get used to it, or run through it a few times, it only takes a couple of minutes to fill in. So if we look at the observations on there, we have got tailor, oops, lazy, shouldn't press that, tailor head palpation, curves above and below the lateral malleolus, inversion and eversion of the calcaneus, bulging of the talonavicular joint, congruence of the medial longitudinal arch, adduction and abduction of the forefoot to the rear foot. Now, one of the good things about assessing the foot this way is that it makes you look at all the things in the different planes. So the frontal plane, sagittal plane, and transverse planes, and it gives you that down the side so you can see what you're looking at. Traditional RCSP and NCSP measurements only look at the frontal plane, so they're neglecting the other two there. It also gives you a scoring system to determine how supinated or pronated your foot is. So it goes from a minus number up to a plus figure. So the more minus it is, the more supinated your foot is, and the more plus it is, the more pronated your foot is. And if it's about 0 to a 5, then you've got, you know, a normal foot, so to speak. But the benefits of doing this way is that it does give you a numerical score, and it's great for those clinicians who do like numbers and like to categorise things. It also gives you a table of observations which can be referred to at a later date by a different clinician, and you know, in fact as well, you could use it as an outcome measure. I've certainly followed up on clinicians before who have filled very little in, and then you're reassessing the patient because they haven't filled anything in, whereas with something like this it gives you a very clear set of observations. So all well and good, but is it repeatable and is it reliable? Well, yes it is. Several studies back that up. First of all, it has been shown that the foot posture index could be associated with walking function, and these authors also found that the test was repeatable too, and interrepeatable amongst practitioners. If we delve a bit further, there are also several studies which have shown a link, or also link the foot posture index to arthritis, patellofemoral pain, and foot and ankle overuse injuries. So Levenger found that the foot posture index correlated to medial knee arthritis, and then Barton found that some parameters of dynamic foot function were linked to individuals with patellofemoral pain, and he used the foot posture index to assess this. And then Kane also found a correlation between foot posture index and injuries to the foot and ankle in indoor football players. So that's to name but a few there, but if nothing else, it is a validated scoring system and it identifies foot posture, and you'll see this is being used more and more in research now. Right, now let's have a look at the position of the subtalar joint axis. This is another test which looks like it takes ages at first, but in actual fact is very, very quick once you're used to doing it. And it also gives you a very precise guide regarding your prescription for custom-made orthoses, or simply if you were just sticking a bit of wedging on an off-the-shelf device. So basically you've got your patient laying supine or prone on their front or on their back, and you're assessing and marking with the pen the points on the plantar aspect of the foot where the foot neither pronates or supinates. And then this gives you an axis line, and it can be either normal, where it runs pretty much from the back of the lateral aspect of the heel to more or less between the first and second toe, or it can be medial, where it comes right over and almost skates off the medial side of the foot there. Or it could be lateral, where it comes obviously right over on the lateral side. Now here's one I did earlier, and as you can see this axis is slightly medially deviated, so we're coming down the medial side. A normal axis we would want probably to come down the middle to between the first and second a little bit. So what this means in clinical terms is that the axis on this particular foot which I've put on here is closer to the main insertion of the post-tib muscle. So that means that this muscle will have to work harder to prevent the foot from pronating because the lever arm is shorter. Also, if I was going to make an orthotic device for this patient, because maybe they're excessively pronating and that's what I want to control, we would need to post medial to the line, as anything that we put on the other side would effectively push the foot the wrong way with some patients. Also, if you have a patient that's got a device that's maybe got a valgus fill or an arch fill, or the posting you've put on crosses that axis, this can be very uncomfortable for them, and it could be a reason why they're not wearing their orthoses. So if you get that sort of patient and you don't normally do this test, it's worth checking, because if they're excessively pronating, this is the bit here that you want to be putting posting on to control that, and you don't want anything on the line or the wrong side of the line. Evidence-wise, that test is a lot of Kevin Kirby's work, and he's written about this at length. I talked about this quite a lot in a webinar which I did last year, so I'm not going to go on about it too much now. But there are references at the end of this for anyone that wants to look at it and read them and look it up a bit further. One thing I will say, and I guess this is a valid point, but a paper by Nestor commented that we don't know that it's just the subtalar joint at play here. There's lots of other joints in the foot, and these could also be a contributing factor to where an axis line lies. But nonetheless, if you do this test, there is a natural axis which does run through the foot. So whether you want to call it the subtalar joint axis or the foot axis, there is an axis there. Now another test which, and this one ties in very nicely with the one we've just done, the subtalar joint axis location test, is the supination resistance test. So this is the one where you ask your patient to stand normally, you use 2 fingers to pull up under the navicular, more or less about the point where the main branch of the post-tib inserts. But you really need to make sure that the patient isn't trying to help you with this, because sometimes they tip their foot over for you because they think you're finding it hard. So you need to make sure they're completely relaxed. But you're basically assessing how hard it is to supinate the foot. Now, I've had small children in a clinic with hypermobility and feet which are pretty much flat to the floor, and I've barely been able to budge their foot. I've also had 20-stone-odd rugby players, and I can tip their foot right over with no effort at all. So this test isn't about the size or the weight of your patient, it's about how hard the muscles are having to work to maintain their foot in that position. So actually this test is actually quite a good indicator for the material that you might use to make your orthotic from. Because if you've got a patient with a high force and you give them a soft density or maybe even a medium density EVA device, for example, then they're going to squash it in pretty much no time at all. So as I said, this ties in nicely with the subtalar joint axis location test. And generally speaking, if your patient has a medially deviated subtalar joint axis, they'll have a high supination resistance because that lever arm is shorter. And if they have a laterally deviated axis, they'll probably have a low supination resistance. So it'll be easy to tip the foot over onto the lateral side because the lateral axis gives you a longer lever arm. So that's enough physics for now, but Craig Payne's written quite a few papers looking at this, and he's found it to be a reliable test and one which correlates quite well with the subtalar joint axis location. So if you're going to do one, it's quite nice to do the other as well, just to justify your findings. Right, okay, so navicular drift and drop. So this test looks at the movement of the navicular as the foot pronates and supinates. And if you remember what I said in a slide earlier on about the talonavicular joint, and most of the articulations occur within this joint, well, this is where this bit comes in. Now, I explained this test a few years ago, and I did come up with some resistance against it, which I'll tell you in a minute. But all you do is you simply mark the prominence of the navicular with a dot, as it's shown on the picture here, and then you use a piece of card or a piece of paper, and you mark, or you use that to see how much the navicular either moves up and down or how much it moves side to side when you pronate or supinate the foot. So the picture on the right there shows it moving up and down, but side to side you can't see, but basically it'll be coming at you, coming that way. Okay, so when you do this, ideally these should be equal, so drift should be the same as drop, and vice versa. But if it isn't, this might alter how you would do your prescription. So for example, if you had maybe a hypermobile child and when you measured this, the navicular drifted, so it came out more than it went up and down, then you might consider something like a high-sided orthotic to control the rate of pronation if that's what you wanted to do, because this would be the plane the movement was occurring in the most. If you just controlled it in a different plane, then you'd probably still get the excessive pronation. They wouldn't find the devices comfortable. So why did I get resistance to this test? Well, in an audience, one chap who was very pro-root just rolled his eyes and said, well, this isn't a very accurate test, just using a bit of card and drawing on there, and you haven't actually measured anything. So I think he possibly missed the point, but hey-ho. And as it turns out, this test has received a lot of attention in the literature, and for quite a few years now as well. So many studies have said that navicular drop may be a more valid indicator of rear foot motion than traditional frontal plane measurements, like your RCSPs and NCSPs. And I think this could be because you're looking at a triplanar movement, whereas traditional frontal plane measurements don't take into consideration what happens in the other two planes. And as we know from our training, supination and pronation is a triplanar movement. Now, in 1998, Mentz felt that the evidence for the navicular drop test was so strong that measurements derived from just heel bisections must be regarded as having little validity. Okay, so this one's Jack's test, or Hubschers test, I don't know what people prefer to call it. Basically, this not only looks at the range of motion and the ease of movement at the first metatarsal phalangeal joint, but it also checks that the foot works as it should do during propulsion and gait. So you need your patient weight bearing, and you need to make sure that you've got a proper hold of the hallux so that your dorsiflexing tongue and a twist, dorsiflexing the right joint. So you want to be dorsiflexing here and not on the IPJ, which if they're hypermobile, you might well be. And what you're checking is that MPJ does actually dorsiflex. You want to see the arch raising and then their tibia and fibula starting to externally rotate. I think I'm right in saying that technically speaking, the Hubschers, if you call it the Hubschers test, you would score this from a 0 to a 3. So if nothing happened at all, you've got a rigid arthritic foot, maybe for example, you score them a 0. And if you lifted the hallux and the arch raised and everything worked and the tib and fib externally rotated, you score them a 3. And then the 1 or the 2 would be in between that, depending on what mechanisms worked. Jack's test is simply just yes, it works or no, it doesn't work. And to justify this, I had a quick look at the research for Hubschers earlier, but it was all in German, so I'm afraid I haven't quoted for that one, so I'll have to go and look that one up. Movement of the first MPJ has received a lot of attention in the literature as well over the years, and Howard Dannenberg has written an awful lot about this, which is worth a further read. But in actual fact, this was first described by a chap called Hicks over 50 years ago, and he describes the hallux almost like a lever which engages the plantar aponeurosis like a winch mechanism, raises the arch, locks the mid-dorsal joint to make it rigid and stable enough to push off from, and then finally the tibia and fibula bring the knee into alignment. Now, this is very much described in engineering terms, but this notion has been supported for over half a century now, and Fuller came to the same conclusions regarding its workings in the year 2000. Now, let's have a look at the lunge test. So I really like this one because it makes so much more sense to me to do this test with a patient weight bearing, and in logical terms it correlates more to dynamic functions such as walking or running than doing a static non-weight bearing measurement of the ankle, which you would normally do with them laying on their tummy or on their back on the couch. So what you need to do is get your patient shown or standing weight bearing like they are in the picture here, and then you need their heel on the ground, and then knee against the wall, and they need to move their foot back, but keeping, as I say, keeping the heel on the ground and keeping the knee against the wall. What you do need to make sure is that they're not cheating, and some patients will excessively pronate their foot because they can't go through the ankle joint, so they'll go round it, so you need to make sure they're not doing that. There's two ways of measuring it. Either you can measure the distance between the wall and their big toe, or you can look at the angle of the tibia. So the angle is probably more accurate because it's not restricted by things like foot size or the height of the patient. So the angle you'd be looking at for normal or adequate function there would be probably about 40 to 45 degrees. Anything less than 40 degrees would be considered as too tight. Okay, so again, this test not only has evidence for repeatability, but it also has evidence for injury prediction. Now, Bennell in 1998 examined the reliability of the lunge test and found it reliable and also interreliable between different practitioners. Although they looked specifically only at young pathology-free physio students, their results also showed that it was predictive of injury. And this has also been supported by a couple of other studies, one of which focuses on football injuries. And what they found was that the distance between the wall and the big toe, or if the distance between the wall and the big toe was less than sort of 9 to 10 centimetres, players were more likely to sustain an overuse injury. So I've talked a lot about the research old and new in some of these slides, but there's a paper which came out only a couple of months ago, which I mentioned earlier, and the authors address the fact that there is no concise gold standard assessment protocol for the foot and ankle, unlike there is at the moment for the knee and the hip. So they used an international expert opinion group which included podiatrists, surgeons, rheumatologists, physiotherapies, and then they adopted the Delphi scoring system to narrow down what initially started as 95 foot and ankle tests, and they brought that down to just 20. And the object of this was to get what they described as an expertly derived set of MSK tests. So their aim was to move a step closer to getting a common database to improve comparability between studies, But some of the tests that they listed, and I'm not going to go through all 20, but some of them were observation of swollen or tender joints, which I guess if you're looking at patients in an arthritis setting, that would be an important test to look at, or important observation. The presence of HAV, or hallux abducto valgus rather. Ankle joint dorsiflexion they've mentioned, although they say this with the patient non-weight bearing with the knee flexed and the knee extended. And first metatarsal phalangeal joint range of motion, and also the foot posture index. Now, I said in the first slide that I wasn't going to tell you what was right or wrong, but you can probably see already that different papers do have conflicting opinions regarding what's important to measure. But I suppose this really depends on what sort of patients you're seeing. So if you're seeing older patients with arthritic joints, you'd probably use some different or maybe more tests or assessments than a clinician who's only seeing younger patients or sports injuries. Another recent paper here by Neil et al., and this was just last year. They did a systematic review of the literature looking at foot posture as a risk for lower limb overuse injuries. And what they found was that of the measures used in the available prospective research papers which they found and which they looked at, the two tests, navicular drop and the foot posture index, were predictive of lower limb overuse injury. So that correlates directly. I guess that makes it all a little bit more, puts it all into more sense and makes it a bit more functional because they're relating it to injury rather than just saying what a test outcome is. But what they went on to say was that dynamic measurements of foot function may display stronger relationships with injury risk. And they then go on to advise that static measurements are all well and good, but they should be used as part of a multifactorial injury risk assessment and not just considered on their own. So you wouldn't, for argument's sake, just do a navicular drop on its own to see if someone's predictive of getting injury. So a bit of food for thought now, and there's just a few things here to bring things a little bit to a close. So while clinicians routinely use foot and ankle assessment measures, the evidence out there to support their use is weak, and in some cases it can be contradicting. Most assessment protocols used in clinic are difficult to standardise because they're based on the clinician's subjective experience of what they consider to be a noteworthy finding. And I guess that's why sometimes we use assessments which have always been used. And if you work maybe in an NHS or a health service trust, you're following on from what somebody's already decided that maybe you're going to look at in clinic. As the previous paper stated, or as Gates's paper stated, this lack of standardisation makes any observation of clinical change difficult over time, or between patients, or between clinicians. But on a more realistic note, if we did argue and ponder the research and the fors and against for everything, then we probably wouldn't even get out of bed in the morning. So at the end of the day, you still need a starting point. And if you use a lab to make your orthoses, you somehow still have to relay to the technicians what it is you want for your patient. The other thing is as well, I mean, for years and years and years, clinicians have used various different assessments or followed various different theories, and patients have got better. So the one thing that I think is important to consider is your own accountability. Now, hopefully none of us are ever going to be sued, but if we did, I think you probably need to think about what justification you have for what you're doing, because I think just saying, oh, this is what I've always done, probably won't cut it. So I guess probably that's where things like the foot posture index come in, because at least you know that is a validated foot scoring system. So on that note, I think I'll draw it to a close. Thank you for listening. I hope everyone was able to hear me in the end. And if you'd like to type some questions in, I'll do my best to answer what I can.